I'm Dr. Malcom pestonji, and my talk today is on UV and TLIF. But before I start that, I would like to thank the organizing committee of Wiroc for giving me this opportunity to address this August gathering of surgeons. UV endotLIF is a procedure that is unilateral biportal endoscopy where visualization of the entire neural structures is immense. One can see everything that one wishes to. It's in a clear fluid medium. There is no blood clot. There is no disadvantage. There is no continuous oozing of blood. It is ideal for all central canal stenosis, facial cysts, and other pathologies, foraminal stenosis, for which we do interlaminar contralateral SAP osteotomy, ipsilateral SAP osteotomy, and for the re-exploration of failed backs. It's far easier to do that. It is very easy for a traditional spine surgeon to adapt to because basically the anatomy is the same. There's a little difference in orientation of scopic anatomy. Much larger size cages can be easily introduced, and I use autologous bone graft which I harvest from the base of the spinous process, the lamina and the facet joint. So I don't really need other extraneous sources of graft. Disadvantages, yes, I have to do it under epidural or general anesthesia. There is always the possibility of a root or a dural tear, and blood loss is relatively a little more in comparison to other forms of endoscopy, but much less than open spine surgery. I'll play this little video and we'll talk at the same time.
We are seeing our cage.
You can
We are
see
seeing
fully
our
compression.
cage nicely.
You can see the skeleton is exposed.
Okay.
You can do
Nicely
contralateral
protected.
surgery.
Free.
That is the cage which you're seeing
Absolutely.
densely deposited deep
No harm
inside.
done to it.
Graft is completely in front of it.
Okay. Thank you very much,
And,
everybody. Now we will be doing a little bit of our dural work.
I will now go to the next slide. Here we are dealing with a patient of degenerative listhesis, and you can see how we have nicely expanded everything, got a good reduction, and done a decent fixation. I will not comment on the fixation part now, but I have the largest series of unilateral fixations done by UB in the world, and till now I have not really had a single patient of implant failure or a cage back out. But that is a story for some other day. This is a patient with retrolisthesis, collapsed disc, and you can see how beautifully we have fixed him. You can see the cage nicely put in, fixation done, and here you can see a video of how I put the cage in. The cage is going in under direct visual observation. It's taking its place in the canal.
Can you hammer it in, please?
And now once that it is fixed into the disc, I'm banging it in. And you can see the cage. It's going in nice and tight.
Going in or no? Yes. Going in or no?
And now the cage is finally getting treated. And we will be putting it into a depth of around 10-15 millimeters beyond the posterior edge of the vertebral bump. Compressing ipsilaterally to make sure it doesn't back.
Shyam, please.
This is the next slide. In a patient of severe stenosis, you can see over here the dural sac is barely visualized. There's a very tight stenosis over here, thickened ligamentum flavum, collapsed degenerative painful segment, claudication, and I opted to do a stenosis decompression. Here you can see a 2-level fixation being carried out, and with only 3 screws. The screws also put in through the same portal through which the endoscopy is done. Here you can see how the facet has been resected over here and over here to completely decompress. UB is advantageous surgery, especially when it comes to doing a redo surgery. A redo surgery is very difficult. Endoscopic TLIF, especially in a recurrent disc herniation, holds a great advantage where one can identify the facet, osteotomize it completely, push away the dural sac with all its adherent tissues, then identify the root which is completely plastered. Here you can see how with a dissector and pushing away the root and identifying the discal surface, which is barely a millimeter across, getting into the discal zone and pushing away the root which is plastered to it completely. Now this would not be possible by a transcambine approach and would result in unnecessary traction on the root at the time of expansion by a cage. You can see the result of the surgery. There's a nice fixation in place and a complete decompression done. This is a case of a redo surgery where previous laminectomy has been done, severe collapse, claudication, pain, and we needed to decompress, elevate height, and do a fixation. Here you see a wonderful scar on the back of a patient who has undergone UB TLIF, and this particular case is of an elderly gentleman, and you can see the patient moving his or her legs. The entire surgery has been done under a sensory epidural block, and our patient is nice and awake throughout the surgery. And there you see him nice and awake. So I hope you enjoy that. And this is a case of stenosis, severe stenosis with instability and UB fixation being carried out. This is again a case of lysis listhesis, bad degenerative listhesis, not lysis. And you can see how fixation has been carried out over here. Good reduction, good height. And lastly, I'd like to thank you all for this kind opportunity given to me to showcase my work. Thank you once again.